Hi, everyone. Thank you for joining us today for our webinar with Riverbend Community Mental Health. Thank you so much, Riverbend, for partnering with us on this series. This is actually a series of 4 webinars. This is the first one. So we encourage you to attend one or all of them, or the ones, the topics that are interesting to you. You can learn more about them on our website, concordnhchamber.com. We have the whole list. If you can't attend all of them live, we are recording them all, and we are recording today's session. So you will receive an email afterwards with the video. If you want to go back and reference anything or share it with a friend, you will get access to that video. But the great thing about being here live today is that you get to ask questions during the event and be part of the conversation. So I'm going to tell you how to do that. If you move your mouse or tap your screen, if you're on mobile, you'll see a button called Q&A pop up. So you'll want to click on Q&A, and then from there you can simply type in your question. The questions are only seen by me and our presenter today, Sarah. So they're anonymous to the other attendees. No one else can see if you're asking something or what you're asking. So please feel free to use that throughout the event. If it's appropriate, we'll interrupt with questions. We'll probably have some time at the end for questions as well, but feel free to add, as we're moving through the topic and going over today's presentation. So thank you again for joining us. Thank you, Riverbend, for this series. And I'd like to introduce Sarah to you.
Great, thanks, Emily. Hi, everyone. My name is Sarah Gagnon. I'm a licensed clinical social worker. I'm the Vice President of Clinical Operations for Riverbend. I've worked as a clinician for Riverbend for about 11 years now. So I'm really happy to be able to present some of this just basic psychoeducation about a lot of really basic mental health conditions that I think a lot of people hear about but don't have a ton of information about. So I'm going to do the best I can to give you as much information as possible, but also kind of keep it at a level that feels digestible. If you have some questions or concerns, feel free to use the Q&A. Also, if you want to talk privately about any questions or concerns that you have, feel free to call Riverbend, and I can give my phone number, my extension here as well if you have any questions. So with that, let's start. So here's some statistics about mental health conditions. As you can see, the statistics are really staggering. 1 in 5 Americans experience mental illness. So we're going to talk a little bit during this presentation about the difference between experiencing mental illness and being diagnosed with a mental illness. This 1 in 5 statistic is very specific to people that have been actually diagnosed with a mental illness. There's going to be lots and lots of people, I'm sure you all, myself included, that have experienced mental health symptoms, but don't actually meet the criteria for being diagnosed with a mental illness. So there's a little bit of a difference there. It's really important that we pay attention that mental illness really doesn't discriminate. It touches everybody in one way or another. Mental illnesses are the leading cause of disabilities worldwide. 1 in 10 full-time employees has a problem with addiction. We're going to be talking about substance use. I'm going to talk about substance use in the time of COVID a little bit too, because things have just been really different during this experience that we've all been having during this pandemic. 40% of employees with a mental illness take time off because of it, and that can be up to 10 days a year. And the one that I think is really important to pay attention to is that HR managers know that the toll of mental illness, what it can take on the company, but only 15% of those managers feel that they've gotten the training to be able to help their employees and staff and people that they're working with. And 35% feel they've received no formal support or training or resources to be able to help their employees. So that's something that, we're trying to work on. I think stigma has a lot to do with people not getting the training that they need. And we'll talk a little bit about that during the presentation as well. I believe the next Riverbend series that the Chamber is going to be hosting is about stigma. So we'll be able to transition some of this psychoeducation into another webinar about stigma later. So these are common conditions, right, that everyone hears about pretty regularly. You're screened for when you go to the doctor. It's pretty easy to talk about these things. I don't know many people that have all of these things at the same time though, right? That would be somebody who needs a lot of medication and somebody who would be pretty physically ill. Why do you think it's easier to talk about these common conditions versus mental health conditions? I have some theories. It's tangible to talk about some of these things. You can get lab tests, you can take medication, and people feel that saying like, I have COPD, that doesn't change who you are as a person. It's something that you have to deal with or something that you get treatment for. So why is it different for these things? I know many people that say that they have experienced symptoms of anxiety and depression on a pretty regular basis. I think that we all have to some degree. Something that I think is going to be important for everyone to pay attention to during this webinar is that all the conditions that I'm going to be talking about today, everything is on a spectrum. Think of it as 0 to 10. 0 being very, very mild or not at all the way up to 10 where this is an extremely important part of your life, where you've been hospitalized perhaps, or gone to an emergency department, or have to seek regular treatment for some of these conditions. So our goal today is to really take the mystery out of some of these conditions and help you gain a deeper understanding. There's a lot of misconception around some of these conditions. One thing that I like to talk about during these trainings is to really pay attention to person-centered language. Well, what does that mean? If we think about the slide before, you don't hear people say, I am cancer, right? It's very rare that you hear somebody relate who they are to their medical condition. But we very often hear people say, I'm depressed, I'm anxious, or they're bipolar, or that person's a schizophrenic. So what happens there is that we're personalizing the disease, that anxiety and depression has become who we are, not something that we're seeking treatment for, or seeking help for. So it's really important that we focus on mental health conditions, just like we focus on medical conditions, to say, these are things that you can be screened for, you can get medication for, you can get treatment for, and that treatment actually works. That these conditions aren't something that you need to suffer for a long period of time, that with treatment, things can actually get better. So let's talk a little bit about anxiety first. So again, I want everyone to be thinking about that spectrum from 0 to 10. So as we start talking about some of these mental health conditions, it's also important to know that everyone experiences anxiety to some degree, probably a mild form. An example of that is stress. I mean, let's look at this list. Restlessness, feeling wound up and edgy and irritable. I'm stressed right now just presenting this because this is something that's new. So stress is very safe. It helps you get things done. It helps you be productive. And it's your body and your mind's way of preparing you for something. So anxiety in a severe form is extremely debilitating. It can be regular panic attacks and the fear of having ongoing panic attacks. It affects your body in really, really deep ways. So there's that mind and body connection, that what's happening mentally is changing the way that your body feels. So think of the fight or flight response. That's a very mild form of anxiety, but it makes us feel very, very tense. It makes us feel like we need to do something right now to get out of this situation that feels very scary. Are we gonna fight the person off? Or are we going to run away? What exactly are we going to do here? So anxiety can also vary on how long it lasts. So it can last for a few minutes, and it can last for years and years and years. So again, that's that spectrum that I'm always referring to. So the median age of onset for anxiety is 11 years old. Let's think about that right now. Think about these kids that are going to school right now. hybrid models, having to wear masks, not seeing their friends. The level of anxiety is rising in our community as a result of COVID. So that's something that we all need to be paying attention to. A little bit further into the presentation, I'll talk a little bit about what to do when we notice some of these symptoms in ourselves or in people that we care about. So a little bit more about anxiety. So there are many different levels, like I said, about how the body reacts to anxiety. So think about cardiovascular, pounding heart, chest pain, rapid pulse, feeling flushed. Respiratory, having a shortness of breath. Neurological, dizziness, having a headache, sweating. Numbness or tingling is something that people talk about a lot. Also gastrointestinal, so choking, having dry mouth, stomach pains, nausea, vomiting, all as a result of stress and anxiety. And then of course there's muscle aches and pains, restlessness, tremors, shaking, inability to relax, are all symptoms of anxiety. There's also many different kinds of anxiety. So when we start talking about diagnosing anxiety, what we're looking for, clinicians, meaning we, talking about functional impairments. So what we look at is, okay, somebody may be saying that they're feeling anxious on a regular daily basis. I want to know, what does it look like for that person? Start walking me through your day, and how does anxiety or any of the symptoms that I listed impact your ability to take care of yourself, to take care of others, to be able to perform at work? Socially, how is that impacting you? So once those functional impairments start to stack up to say, I can't do a lot of things that I want to do because of my level of anxiety, then we're going to start talking about what a diagnosis might look like. So generalized anxiety disorder is probably the most common anxiety-related diagnosis, and it's about having excessive worry. Excessive worry about money, health, family, work, but even when there's no signs of trouble. So that's what makes it diagnosable. So you can't stop worrying about these things, but there's no reason why we should be worrying. Panic disorders. We talked about panic disorders a little bit previously. Panic disorders are really, really scary. If you have ever had a panic disorder or know somebody or have seen somebody have a panic disorder, it truly feels like somebody's having a heart attack. Their body is reacting in a way that they can't control, and it's very, very scary for them. And it can last just a couple minutes, but those couple of minutes feel like an eternity. And it takes a long time for your body to regulate after a panic attack has happened. What makes a panic attack diagnosable is persistently worrying about having another panic attack. So you may have had a panic attack, but what makes it really scary and diagnosable is that you can't stop thinking about when you're going to have another one. And that's really terrifying for people because of that really awful body reaction that people have. Also, there's phobias. So I think phobias, it's interesting. There's a lot of like shows on TV about interesting phobias that people have. It's almost become like phobias and OCD have kind of become like interesting to the general public, which I always think it's interesting when like networks start having shows about people with substance use and OCD, because it makes us interested. But we have to be really careful about how that stigmatizes people as well. So make sure you're always keeping your lens on about what does that mean for that person or that family or other people that experience OCD and phobias. So a phobic disorder is when you avoid or restrict any activities due to a persistent or excessive fear about a plethora of different things. So we're also going to be talking a little bit about acute stress disorder and how that relates to post-traumatic stress disorder. The next slide is actually on trauma. So trauma in general, we think of a trauma unit in a hospital, right? It's about usually the emergency department. We can think about trauma that's happened to our bodies in both a physical, medical way and also a mental way. So traumatic events can be shocking, scary, dangerous experiences that can affect somebody emotionally and physically. It also can be that you have witnessed a traumatic event that someone else is going through. Think about like when you witness a car accident. Might be take a little while for you to get that car accident out of your mind. So there are major symptoms of PTSD. Keep in mind that everyone that has experienced trauma, even those like really high level traumas, not everyone who's experienced trauma has a diagnosis of PTSD. That's one of those things that we hear a lot, similar to somebody saying, oh, that person is really bipolar because their moods are up and down all the time. Obviously, that's not an accurate description of what bipolar disorder is. Same thing with PTSD. It's easy for someone to say, I've had some terrible trauma in my life, I definitely have PTSD. What is diagnosable about PTSD is the fear of re-experiencing the trauma, and actually re-experiencing the trauma through reoccurring dreams, flashbacks, intrusive memories. So once that starts to happen, then it's like you can't get the trauma out of your head at all because you don't have a break from it. You're having nightmares, you're having these flashbacks, and it's terrifying for that person. So keep in mind, like when I say that spectrum, I'm going to keep referring to that. This could be natural disasters, could be traumatic for people. Car accidents, like I said, and it can also be vicarious trauma. But it's not quite PTSD until you have that reoccurring experience of trauma. Trauma is also, I want to normalize this, everyone has been through really tough stuff in their lives. Everybody has their own story. Trauma can also be losing somebody that you care about. I think a lot about how COVID has impacted us and how much more trauma people have because of the fear of getting COVID, of seeing somebody maybe pass away because of COVID. Everything in our society has been bumped up a little bit because of this pandemic that we're all trying to get through together. So depression and mood disorders. So I think that depression is probably the one condition that we're all talking about here that people feel probably the most ashamed about, because feeling depressed does not feel like yourself at all. Like when I was talking about anxiety and feeling stressed, I think it's like everyone feels stress. We talk about stress a lot. We talk about what we do to cope with stress and anxiety a lot. Depression, not quite so much. It's kind of this hidden layer that we all have, that we have a sad day. Do we always say that we're depressed? Not really. We're saying we're having a blue day. We're having a tough day. But we all have some episodes of mild depression. And it's really important that we pay attention to that within one another, because depression is one of these things that can just start growing slowly. And without the correct treatment or intervention, it can get really, really scary for people. There's also different levels and different types of depression. So there's persistent depressive disorder, which used to be called dysthymia. So this is an ongoing, very, very like moderate level of depression. You know, I used to think of it when I was in college learning about this stuff. I was thinking like Eeyore, you know, was just always really blue, could never really get out of that. That is dysthymia, or the persistent depressive disorder. You never quite get so depressed that you think about perhaps hurting yourself, but you can't ever get out of that funk. Postpartum depression. So actually last year I did an entire training based on postpartum and motherhood and mental illness. And postpartum is definitely one of these disorders that no one likes to talk about. You're not allowed to feel sad when you have a new baby. You're supposed to think that everything is so wonderful and so great. Realistically, your body has gone through a tremendous amount of hormonal changes. You're not sleeping at all. And if you're nursing, there's this extra layer of hormonal changes and how difficult that can be. Nursing doesn't come easily for everyone. So postpartum depression is actually diagnosed in 1 in 9 women, but it's more like 50% of women actually feel some type of postpartum depression after they have had a child. That's a really scary thing. People don't like to talk about it. Like I mentioned before with depression, it's kind of this underlying thing that people just don't like to talk about. It's shameful. It's especially shameful for new mothers. Like I said, you're supposed to be happy. And if you're not feeling happy, people start to get really concerned about, well, what's going on? How come Sarah's not thrilled that she has this newborn? So postpartum depression, along with all the other conditions that we're talking about, like I keep saying, definitely treatable. Therapy works great for a lot of these conditions. I'll talk a little bit about treatment later. I just want to make sure that I always kind of instill that no matter what we're talking about today, there's always hope that something's going to get better with the correct interventions. Postpartum depression, I think, is one of those ones because it's near and dear to my heart. It's important that we're always telling new moms that they have the support that they need, and if they don't feel good, it's okay. And what can we do to help you? So psychotic depression is really interesting. So this is when people start to get a very, very, very bad level of depression. I was going to say low level, but it's a really, really tough depressive episode where they actually start to become psychotic. So what's happening in the brain in terms of biochemistry is your brain is not getting the right chemicals to where they need to go. Your neurotransmitters are not working correctly when you're in that low level of depression. So what ends up happening for people with psychotic depression is that the neurons start firing off these signals and the wrong neurons start picking them up. So people that can be extremely depressed can also start smelling things, hearing things, and seeing things that aren't there. But when they're not depressed, those symptoms could actually completely go away. So it's really tough to diagnose unless you're treating or assessing a person when they're in that state. So the word depression in general is used in a lot of ways. People can feel sad or blue when bad things happen. But I want everyone to really pay attention to what meets the criteria for depression. And it's usually a sad mood, and loss of enjoyment or interest in activities. It's also known as anhedonia. So, but this is not just feeling sad, it's feeling so sad that you start to lose hope that things are ever going to get better. And you can also experience symptoms of lack of energy, feeling tired, feeling worthless, feeling guilty, thinking about death or wishing to be dead. Difficulty concentrating, making decisions, really moving slowly, not feeling like you have any of the energy to get to where you need to go. So I just mentioned something that people maybe cringed a little bit, was thinking often about death or wishing to be dead. There's a common misconception that if you ask somebody if they are suicidal, that you're actually going to trigger thoughts of suicide and actually start having that person think about ways to do it. That is a common misconception. It's absolutely false. The number one way to prevent suicide is to ask somebody if they've ever had those thoughts and if they're having those thoughts now. It's a really uncomfortable and scary thing to ask, even as a clinician who's done this many, many times. When you ask somebody if they have ever been suicidal and if they're currently suicidal, you're really kind of opening up this box and you're just not quite sure what you're going to see inside when you look in. But keep in mind that asking somebody that question can save their life. It's important to pair asking that question with the correct resources. So what you're going to see at the very end of all of this presentation is a phone number for our crisis line. If you or somebody you love have felt suicidal or currently are feeling suicidal, that's the phone number to call. You're going to talk to a clinician just like me on the other end who will kind of talk to you about what's going on, and they can actually come out to you, to your home, or meet with you somewhere else to do a little bit more of a thorough assessment to see how Riverbend can actually help you get through this difficult time. So you'll see that there's other types of depression here as well. Seasonal affective disorder. And bipolar disorder was actually a mood disorder. So seasonal affective disorder, also known as seasonal depression, it affects a lot of us in New England because we don't get the sunlight that we need during the winter. Again, it's all about our vitamin B levels, not getting the vitamin B that we need from the sunlight during the winter time. Oftentimes PCPs, sorry, I try not to speak in acronym, primary care physicians will actually prescribe really high doses of vitamin B. You can also get a lamp that can shoot off some UV rays to be able to help create your own serotonin. But that is a very, very common disorder that happens to a lot of people that just don't get enough outside sunlight time. Also, the winter is long in New England. It is really tough. It's cold, and it can make people feel like they are not themselves, that they are in this dark spot, that spring is never going to come, and it can be really scary. Luckily, a lot of primary care physicians in this area are well trained in having to be able to prescribe short-term medication to help people through seasonal affective disorder. Or even if you've experienced that before, it's the fall now. Start talking to your PCP now about what you can do to be able to prepare for the winter so you don't end up experiencing those really dark feelings again. So bipolar disorder is really interesting. So I think I hear a lot, like TV shows, off the cuff, social media about somebody being so bipolar. I know I mentioned that before in the presentation, where people think that when somebody is moody, have up and down moods or change their mind or make decisions differently, that, oh, they're so bipolar. And I can't stand that because bipolar disorder is really, really scary for the people that have it. It is identified as significant episodic changes that somebody has that can be manic, which is when somebody is very, very hyper, lack need of sleep. They can be very grandiose and think that they can write a novel or solve huge math equations. It can also be characterized by really, really down low major depressive episodes where you can go from feeling manic for a period of time to crashing and feeling depressed and suicidal for a period of time. It is really, really hard to regulate bipolar disorder because in between those episodes, there can be a long period of a baseline. So baseline is like how we typically feel on our normal day. So somebody can experience those things and then be okay without medications for a period of time. But what the medications do is it stops you from going into mania and to depression again. So there's different types of bipolar disorder that I won't get into the details now, but bipolar disorder, I just want everyone to be thinking with their stigma hats on, their anti-stigma hats on, I should say, that when you hear people say that, you know, it's not okay to be throwing out different diagnoses for people to really try to explain their current state of mind or behavior. Pay attention to that. Let's all stop trying to use that language. So something I want everyone to pay attention to as well is anxiety, trauma, depression, the three conditions that I was talking about. It's easy to be on a PowerPoint, right? And just like see all these bullets and be like, oh, you know, this is what makes bipolar disorder, or this is what makes depressive disorder. These three things work really, really closely in unison. Somebody who feels depressed may also feel very, very anxious. Somebody who has post-traumatic stress disorder definitely feels anxiety and depression on a regular level. And people who are anxious could definitely be feeling depressed because they're not able to perform the way they want to perform. So it's really hard to tease out these three. It's important that we're all paying attention to what everyone's individual experience is. And one thing that I think is particularly tricky is that a lot of people can say, I felt anxious, I felt depressed. But in order to tease it out, to figure out how we can help that person the most, it's important to ask, what does that look like for you? Tell me what depression looks like for you. Does it mean that you're crying on and off during the day? Or does it mean that you're stuck in bed? Does it mean that you've gained a lot of weight or lost a lot of weight in a short period of time? What does anxiety look like for you? Everyone is different. Even though the criteria the symptomatic criteria to actually be diagnosed with each of these really feels like a small box, but we can't be putting people in boxes. People come to us because they say that they need help, and we need to honor whatever their experience is of these different mental health conditions. So make sure that you ask. Again, there is no need to suffer with any of these conditions. There's very, very effective therapy models that I can speak for Riverbend, that most of our clinicians are trained in cognitive behavior therapy, which has been proven to be able to decrease depression, anxiety, symptoms of trauma from therapy alone. No need for medication. Sometimes what we find that people that have had therapy for a period of time that still experience these uncomfortable symptoms, it is good to pair the therapeutic intervention with medication from either a primary care physician or a psychiatrist. And that combination can be really effective if people have been dealing with some of these conditions on a chronic basis. So substance use disorders. The number one thing I want everyone to remember and to take away from this is addiction is a mental illness. A lot of people, or I hear a lot of people say that, well, it's somebody's choice to keep picking up the bottle to drink or to keep injecting themselves. And it's really difficult to tease that out. I think I can guarantee that the person who is addicted to heroin doesn't want to be addicted to heroin anymore. At some point, the high goes away. The feeling of being drunk goes away, and you're left with this empty shell of a feeling. That doesn't feel good. That's what addiction leaves people with. That is a mental illness. Addiction can transfer to different things. So I've heard examples of somebody who used to be an alcoholic, but now they don't drink anymore, but boy, they eat a lot and they've gained a lot of weight, or they shop a lot, or they have a sex addiction. So it's important that we think of addiction as a mental illness, not just alcoholism or opioid use. All of these things work together under an umbrella of addiction. So 8% of the world's population has substance use disorder. That feels tiny when we think about the world, but it's important to think of 1 in 10 full-time employees has an addiction. Again, could not be substance use. It could be gambling. It could be shopping. It could be sex addiction. But I want everyone to think about that staggering number. And over 60,000 Granite Staters are actually in recovery. So that means that they have sustained recovery for, it's usually about a year or two to be able to say that you're in full recovery, depending on the level of use that you were previously experiencing. So there is a difference between a substance use disorder and substance dependence disorder. So not everyone who uses substances has a substance use disorder, just like not everyone who experiences anxiety, depression actually has a diagnosable disorder. The difference is with substance use disorders, what happens is it leads to work, school, home, or other legal problems. With dependence, then you're talking about how the tolerance for the substances has changed in the person's body, that there are problems with withdrawal. You end up using larger amounts over a period of time, and problems cutting down and controlling it is very difficult. Sometimes substance dependence can require medical intervention. Alcohol dependence is the only detox that actually needs hospitalization, however. Opioid use, I think it's a common misconception that people that have opioid use disorder actually need to be inpatient somewhere, and that's not entirely true. If you're able to work with somebody who is able to prescribe medically assisted treatment, you can actually get the help that you need from home. Usually for people, it feels better to get that treatment somewhere else because sometimes the home environment is part of the problem. But it's important for people to know that detox from alcohol can cause seizures. If you know somebody who is drinking a lot, it's important that they talk to their primary care physician about trying to get off of alcohol. It's really difficult to do that safely without medical intervention. So let's talk a little bit about COVID and how this has changed substance use disorders. So something interesting started happening once everything started shutting down. People started socially isolating more. We noticed that our calls for our substance use program dropped significantly. We have multiple different programs. We have a program called The Doorway, where people can call to get an assessment referral to whatever level of substance use services that they need. Those calls statewide dropped dramatically. And the calls that started increasing dramatically were calls for inpatient detox, because people started to get so sick that they needed to be inpatient to get the help that they needed. It's really scary right now that people are home and are using, people are isolating. If you are worried about somebody, what to do next is what we should talk about now. The number one thing to do is to talk about it. It's uncomfortable to talk about it, but to talk about it with the person you're worried about, and to even notice it with them or yourself, to say, hey, I noticed that you haven't been doing X, Y, and Z. You haven't been, let's say, exercising as much as you used to because you're home drinking. I wonder what that's about and how that feels for you, because you used to love to exercise. Notice some of these changes in a very gentle way and come from a place of support and wondering. I wonder what it's like for you to be experiencing X, Y, and Z. I think the easiest person to call for help is probably the person's primary care physician. You, of course, can call Riverbend, but usually with substance use disorders, people aren't in the right stage of change to be able to jump right to action. So stages of change is something that we talk about in one of the therapeutic models called motivational interviewing. And what we do is we talk about when somebody is thinking about making a change but not quite there, or maybe they've tried to make a change but they weren't successful, or maybe they're actually preparing to call Riverbend for treatment, and what does that look like? So stages of change is something that's really important that we should all be thinking about in the back of our minds, but calling somebody's primary care physician is a really kind of gentle, hey, I've noticed that you're drinking more than you used to. Why don't you talk to your doctor about that? I wonder what that conversation might look like. So here's our last slide, just talking about what our crisis line is. This big red phone number is the number I was talking about before. If you or somebody that you love or care about is in crisis and needs to talk to somebody, this is the phone number to call. If you are inquiring about services for adults or for children, here are the two phone numbers. The crisis line is a great way to get some quick information and to be able to get an assessment for somebody that you care about or yourself.
Well, thank you, Sarah. So, feel free to submit questions if you have some. Again, how to do that, move your mouse, tap your screen. You'll see a little button that says Q&A, and from there you can just type in your question, and we'll see it. It will be, anonymous for everyone else. But I do want to kick things off with, I have a few questions. So, Sarah, when you, whether it's a friend or a coworker or a family member, I know some people have concerns about, does my insurance cover mental health? Do you have advice on addressing that? Or I don't know much about it, clarification on how that works.
Yeah, the insurance piece is really tricky because every insurance carrier covers different things. If you're curious about what it covers, you can always go online and take a look at your your program to be able to see what it's covered. You can also call that phone number on the back of the insurance card to say, hey, I'm curious, I have, you know, Anthem, let's say, and I'm curious what is covered under that. But also, once you start, if you were to call Riverbend for services, that's part of the conversation too, is as soon as the intake happens, we're having a conversation with you about what it's going to look like for you financially, because we don't want finances to get in the way of services at all. We want to work with you. We want to talk to you about what to expect. And we don't, if somebody says like, I can only afford, my copay is whatever, but I can only afford this, we're going to work with you and talk to you about how to get over that obstacle. So you can call your insurance company yourself, or you can let Riverbend do the work for you.
All right, that's really good to know. You know, and that's comforting for people to know that they're not suddenly financially getting in deep, especially if maybe they're already anxious about, you know, money, and that's one of their concerns. I was so struck by the statistic you said about people taking time off for their mental illness. So, you know, do people take time off out of their sick time? Is that something that you would encourage employers to talk about, having, you know, time that can be used for mental health and physical health?
You know, that's a really good question, Emily, because I think, again, stigma has a lot to do with these conversations. So it feels easier to take a quote unquote mental health day where you're just taking a random day off. I can't come into work today because I'm not feeling good, right? But it's also important to have a conversation. If you're getting treatment for any of the things that I listed today or anything else, it's really important to talk to your HR director, HR person about what that looks like for you. To say, hey, maybe I need to sign up for Family Medical Leave Act because regularly I have, you know, panic attacks that takes me a couple days to recover from that, or major depressive episodes that are really hard for me to get out of. So having a lot of conversation with your HR department about that, not only does it help them plan for supporting you more, but it also decreases stigma and offers more education as well.
That's good advice. And I can imagine Riverbend you work with people to, you know, if they're anxious about talking to their HR person, you know, you can help guide them with that as well, because that's a tough conversation. So what about on the other side, if you are an HR you know, person and someone asks you, you know, brings this up that they need to take more time off, or, you know, do you have advice on how to you know, handle that conversation in a way that's really supportive, but also, you know, it's part of your job and you have to, you know, be professional as well?
Absolutely. So 2 things that I would suggest for any HR professionals out there is, one, to think of this just like it would be any other medical condition, because mental illness is a medical condition, right? So think of it that way in terms of what you need to pay attention to for FMLA and signing up for short-term leave and things like that. But also ask that person what it looks like for them. Just like I mentioned before, I think it's scary for us to think like somebody says, hey, I get depressed on a regular basis. All of a sudden, it's easy for us to lock up and not ask any more questions because we're afraid where that conversation is going to go. But it's okay too, as long as you can say like, wow, it seems like you need more support. Have you ever thought about calling Riverbend, or have you ever thought about talking to your doctor about that? So it's okay to ask a few more questions, because once you get the full story of what it looks like for that person, then you can start to shape how you can support that person in the workplace.
Okay, yeah, good advice. So you talked a little bit about, you know, asking someone if they've had suicidal thoughts or if they've been suicidal, and how that's, you know, not actually, you know, triggering for those conditions, and it can be really important. So what if, you know, you have a coworker who you see is really struggling with anxiety? Does the same hold true? Is it positive to ask, you know, are you struggling with anxiety, or are you struggling with addiction? Is that a good thing to ask?
So I guess my advice on that is that I wouldn't name it as much as I would name the suicidal question, right? So
Okay.
it's proven to ask, if you ask somebody, hey, have you ever experienced suicidal thoughts, or are you currently suicidal, that it does decrease the likelihood of them actually acting upon their thoughts. The other way for other conditions doesn't work as well. So instead of saying, hey, you look really anxious, or it looks like you may be experiencing X, Y, and Z, what you want to ask is, hey, you seem different today. Or I'm noticing these things in you that look a little bit different than the person that I knew prior to COVID. Are you okay? How can I help you? Have you ever thought about calling whoever, whether it's Riverbend, a family member, or your primary care physician, for more support or information about this?
Yeah, that's great advice. So I have one more question, but I'll slide in there. I am asking all the questions here. If anyone else has a question, don't be shy. You can submit it through the Q&A portal, and we'll answer it. Oh, I think we just got one. So here we go. Are people really honest when asked if they are suicidal or depressed? What if you have concerns that they are, but they say no?
Yeah, that's really tricky. So somebody would like to answer the question live, it says.
Oh, I think I clicked that as in we're doing it now.
I was like, oh, interesting. So I guess what I would say about that is, when we do crisis assessments for like children and adolescents, let's say, they often backpedal and say, no, I didn't say that, or no, I don't think that, no, I don't mean that. It's also, whether it's children or adults, it's really shameful to talk about some of these things. It's scary. They don't know what's going to happen after they say, yes, I've been having thoughts to hurt myself. So what I would suggest is to ask in different ways. If somebody says, no, I've never been suicidal, but you're really concerned about them, say, okay, well, I'm really wondering about that post that you had on Facebook where it just seemed like you were really, really down and you were having some dark thoughts. Can you talk to me a little bit more about that? So trying to get at it from different angles sometimes feels more supportive and less scary for that person. But some people will say, yeah, I've had thoughts about hurting myself. And it's tricky for the person asking to know what to do after that, because now you're holding this information. And that's why I know I keep talking about this crisis line, but we get a lot of people that call the crisis line because they're worried about somebody else and they're not quite sure what to do. Or they're working with somebody and they call with that person, but that person doesn't want to talk to us. So we're in a tricky situation, but that's where we come from, a place of support and education to be able to say, here are your options. Here are some of the things that you can say. Here are some of the services that Riverbend can provide to be helpful.
It's kind of comforting to hear that the calls don't always come from the person themselves who's, suffering. Makes it seem more okay to just call and ask, because I think when in doubt, we want to utilize that resource that we have here in our community that Riverbend does provide.
I think the scariest thing is that, when you have someone in your life that you're really worried about and they're not at that stage of change to get the help that they need, and you feel kind of powerless to be able to help them. So that's why arming yourself with information is the best thing you can do. So when they have that moment of, yeah, you're right, I haven't been myself and I don't know what to do to make it better, you can say, well, actually, here's a list of options. You can talk to Riverbend, your primary care physician, the crisis line, who are people that you feel like you can talk to that are the most supportive in your life. That type of information is really helpful for people when they're in that small window of space that they can actually be like, I want to do something.
Yeah. All right, so I have my last question. I think my last question for you. So, we're holding this series right now because, I feel like it's really important that we talk about mental health right now during the pandemic. So many people have been furloughed, stuck at home, dealing with anxiety. We all know that. But do you have statistics or, information that Riverbend has seen and why this is important? Maybe how things have changed, and does that affect strategy at all when you're working with people who may be suffering or something like that?
Yeah, so, I'm always a little shy when it comes to talking about statistics right off the top of my head, because what is it, like 75% of statistics are made up on the spot? Yeah. But what I can talk about is a little bit of Riverbend's experience through this whole COVID time and what we've noticed. So once things started closing down, we started researching to say, what are we going to prepare for? Everybody started hearing about the mental health surge, and when is that going to happen, and what is that going to look like for people? So we started doing some research about what mental health issues started coming up after the recession. We didn't have anything really to pull from in terms of a pandemic, so we went to the most recent thing that we could find that would be helpful. Also, the economic piece of this is important for us to pay attention to. What we started noticing is that after the recession, people that were working and employed experienced 5 times more mental health conditions than they did previously. And also that these suicide rates increased by 13%. And that's people that were actively employed and had insurance. I think about people who have been home because already of their mental health condition that can't work because of their mental health condition. And I can only anticipate that that rate would increase based on that population. So we started seeing some interesting things. We started seeing calls spike as soon as we knew that the schools were closed, right? People were starting to freak out, wasn't quite sure what to do. Then things started to even out a little bit. Substance use calls, like I mentioned before, were down, are still down actually. We've noticed a lot of crisis calls starting to increase. And a lot of the calls were from family members and from people that have never experienced mental health conditions before or have never sought treatment before. So they were calling us being like, this is so different for me. I don't know what to do. I don't feel good, and I'm not quite sure what to do next. We also started our own clients, thousands of people that we serve. We started seeing more crisis calls from them because a lot of our service delivery lines used to be in person in their home. So we're still able to do some in person and in the home with adequate PPE and things like that, but it still feels different for people. So they weren't feeling like they were getting the same level of support as they did before. So we've noticed these trends, and with the schools reopening and going to hybrid models and all kinds of different models across different school districts, we've seen definitely an increase in calls for children and families.
Yeah, those are huge shifts in numbers, and that just you have observed. Wow.
I think what I can say for a statistic is between March and April, we received 100 more crisis calls than we did the month before.
Wow.
Mm-hmm.
Yeah, that's a lot. This is a really scary issue. Yeah. Any other final thoughts you want to add? As we're wrapping up here.
Sure. I guess the last thing I want to reiterate, because I said it before, and it is Riverbend's motto, but treatment does work. Whether it's individual therapy and medications, case management, reaching out for one person, that's the bravest day they've had in a long time. And we want to pay attention to that. We want to give them all the support that they need on that first call to make sure that they're able to get to where they need to go. Riverbend has a huge variety of services to meet people where they're at and to make sure that they're getting their help that they need at the right time. And don't be afraid of asking for help, because as soon as you do, things can start to get better, and that there's always hope.
Yeah, thank you, Sarah.
You're welcome.
That was, I feel like I learned so much, and that was, such a good end. Oh, I think I actually see one. Oh, we just got a thank you for the presentation. I thought we had a question. So I'm gonna wrap up and just share some chamber news, before we close. So I'm gonna put something on screen. Just a second.
Oh, while you do that, Emily, I did want to say I was going to give out my phone number in case anybody needed to call to talk about specific situations or anything personal that they didn't quite want to call the crisis line about. So my phone number is 603-226-7505, and I'm at extension 5047. I have a confidential voicemail. Feel free to give me a call and ask any questions that you might have.
Great. And again, you know, we're recording this, so if you need that phone number, again, you can watch the video and take that down if you have any, you know, deeper questions you want to talk about more. So switching gears here to chamber news, I just want to let you know about a few things that are going on. First off, again, this is the first in a series of webinars that we're doing with Riverbend about mental health. So as Sarah said, the next one is about stigma. Then we have creating a culture of wellness and optimizing human resources. These are all going to be really good presentations. I know already, I've seen the outline. They're, you know, the topics are really important right now. So whether you attend them all, you just, you know, watch one or two. We are going to be recording them all, so you can go back to the Chamber website and watch all the videos. But I do encourage you to sign up for the next ones. Other things going on, we are continuing our virtual networking events. I think we've all kind of in the theme of today felt loneliness with the pandemic, and we're really glad to provide this opportunity for you to connect with people. What it actually looks like is, so we have tons of people join us, but we put everyone in small groups so that they can socialize, you know, in a way that you would naturally at an in-person event. So you're maybe in a room with 4 or 5 people, you can have a real conversation. We give a little prompt to get you talking, so it's a little easier. So if you're interested in that, we do provide detailed instructions that teach you how to join us if you know you're new to Zoom and that type of thing. So consider signing up. A week from today is our next one. And then we're also continuing our webinar series with Orrin Reno, PA. They covered some really important COVID topics this spring, and we're excited that they're continuing to cover things that are very, very timely. I actually don't know what the presentation is for our next session because it is so timely. They wait until they know what's really important, and then we'll talk about that. So for any of these events, you can go to concordnhchamber.com to learn more, or feel free to reach out to anyone at the Chamber and we can give you more info. So thank you again for everyone who joined today. Thank you so much, Sarah.
Thanks for having me.
Yeah, great presentation, and so glad we could continue the conversation more. So hope to see you all at the next webinar event. All right, thanks.